Good afternoon, everybody. Myself, Dr. SUDHANSHU SHEKHAR. Let's come to the case details. A 40-year male patient came to our IOPD 8 months back with chief complaint of diminution of vision in both eye, left eye more than left right eye since 1 year, and there is worsening from past 1 month. The sudden blur of vision in left eye since 1 month, history of metamorphopsia in left eye, no history of macropsia, no history of pain, headache, bulbar injections, or flashes, floaters. There is similar history of 1 year back in left eye, which resolved spontaneously within few months. History of a stressful life for few months. Known case of diabetes mellitus 5 year and hypertension since 2 year, which is under medication. Family history was nothing significant. Personal history nothing significant. On ocular examination, anterior segments were normal, but visual acuity, base corrected visual acuity, right eye was 6/9 and left eye 6/36. On fundoscopy, the right eye media were clear, CDR 0.4, vessels normal, AV ratio 1:3, FR present, and left eye CDR 0.4. There was blur margins in superior nasal to disc and some hyporeflective discoloration area superior to disc, probably exudations. Veno-occlusive changes seen along the inferior arcuate vessels and some soft exudates in the retina, and few superficial hemorrhages were seen. FR were dull and multiple hypopigmented dots were seen around the macula, and striations was also seen. We did OCT, and the right eye OCT line scan showed shallow SRF superior temporal to fovea, and the left eye OCT showed SRF fluid extending from disc till temporal to fovea, subretinal discrete hyperreflective dots, which typically chronicity, and the thickening of RNFL layer towards the disc and irregularity in the inner retina. We did the OCT disc also. The left eye OCT disc showed shallow SRF and retinal thickening with some cystic space in the outer retinal superior to disc and subretinal hyperreflective dots exudations superior to disc. We did FFA after that. Right eye FFA showed window defects temporal to fovea, foveal leak superior temporal to disc, superior temporal to fovea, ill-defined leak at superior temporal quadrant arcades. And in left eye, FFA showed hyperreflective disc followed by leakage superior temporal quadrant to disc, diffuse leakage and a stippling pattern at the macula. The BS scan were normal, vitreous were anechoic, no sign of, no T sign. Provisional diagnosis came right eye acute onset CSCR and left eye multifocal CSCR with occlusive retinal vascular disease. Differential diagnosis diffuse posterior scleritis in left eye, ARMD with CNVM, PCV, diabetic papillopathy, multifocal CSCR with occlusive retinal vascular disease. Treatment that I planned for right eye, I planned for observation because it was acute in onset, and in left eye I planned for intravitreal anti-VEGF brolucizumab 6 mg 0.05 ml and follow-up of after 1 month. On first follow-up after 1 month, the best corrected visual acuity right eye was 6/24, which worsened, and in left eye 6/12. OCT we did on the same day, which revealed right eye subretinal fluid accumulated around the macula, and in left eye it was dissolving subretinal fluid and resolving disc edema. We did the FFA on the same day to look for the point of leakage in right eye, and we planned for the Andiag laser, focal laser. In second follow-up, best corrected visual acuity came up to 6/9 in both. In left eye 6/9 part, and right eye OCT showed a good result with resolving SRF, and left eye also showed resolving disc edema with no superficial hemorrhage were seen, and no SRF fluid. Let's come to discussion. In our case, diagnosis of both eye multifocal CSCR, atypical finding in left eye was made. Patient was treated with 1 intravitreal injection in left eye and focal laser in right eye with SRF resolution at the 3rd month. The multifocal CSCR can rarely show atypical finding like disc edema, disc leakage, excessive subretinal exudations, and can also be associated with overlapping disease like occlusive retinal vascular diseases. Important risk factors are male, and age is 30 to 50 years, type A personality, stressful life. Steroid use is basically related to it. Imbalance between the sympathetic and parasympathetic activity has been associated. The pathogenesis is to the RPE dysfunction and choroidal dysfunction theory.